So welcome to the fully guided, full arch, immediate implant reconstruction webinar. It is being presented by Dr. Michael Picos, and we will begin shortly. And now it is my dearest pleasure to introduce Terry Capriolo. She is a general manager of implant solutions and guided surgery. And tonight she will be introducing our guest star.
Thank you so much, Jessica, and thank you to everyone for joining us. It is my absolute honor and pleasure to introduce our presenter. Dr. Michael Picos is an oral and maxillofacial surgeon and the founder of the Picos Institute, where he has been teaching a continuum of bone and soft tissue grafting along with CT technology since 1991. A graduate of The Ohio State University and College of Dentistry, he is a well-published author and has lectured extensively on implant surgical reconstruction around the world. In addition to his numerous professional organization memberships and university faculty appointments, Dr. Picos maintains a private practice in Palm Harbor, Florida, that is limited exclusively to implant surgical reconstruction. Dr. Picos has been a longstanding partner of the InSequence protocol and one of the top and best educators in the entire world. We couldn't appreciate his support, hard work, collaboration, and friendship more than we do. And we are really looking forward to doing more together on our workflow as it continues to evolve and expand. With no further ado, Dr. Michael Picos.
Well, thank you, Terry, very much. Indeed, it's a pleasure and an honor to be able to participate in this particular webinar. Just a quick disclosure, as you're seeing here on the screen, I am a consultant for National Dentex, and I do receive honoraria for lecturing as well. And of course, I've got ongoing courses that I've been teaching here at the Institute since 2009. So just important to disclose that, certainly. My topic, as you see here, is certainly fully guided full arch immediate implant reconstruction, specifically dealing with the InSequence prosthetic protocol that I have been really fortunate to be part of since 2009. The evolution of the technology has been impressive. The innovations have been very just interesting and ongoing, and myself and my team, we've been able to participate in a number of the innovative elements that have occurred over time. And again, it's been quite a journey, to say the least. Just a few words about myself and what I'm about. Those of you that don't know, I've been in private practice now for 39 years as an oral maxillofacial surgeon. I would say the last, 27 of those years, really devoted exclusively to the implant surgical realm. So it's been an interesting journey for me. I've enjoyed my private practice for sure. In fact, I'm very fortunate to have a great team with me. 4 of us are surgeons, 2 periodontists, and a prosthodontist. The surgeons are Dr. Ken Anderson here from Minnesota, Nicole Hernandez, who's a native of Tampa, trained at San Antonio. She's our dual degree surgeon. More recent addition is Austin Lyman as an oral maxillofacial surgeon. Our periodontists are Lindsay, my daughter Lindsay, and son Tony. And last but not least, Philip Hedger, prosthodontist, been with us now 7 years. So under one roof, we're able to do quite a few things. We do have several, actually 5 offices total. And but our teaching center and our same-day teeth center really focuses on full arch immediate reconstruction. And Phil plays a huge role as a prosthodontist, without question. I'd be remiss to not also introduce another team member who happens to be my wife. She's a nurse anesthetist and does the anesthesia work for us for full arch cases. And my bride of 35 years really has been quite an honor, pleasure to be with her all this time, 35 plus 2 years of dating. Can't say enough about the rock that she has been for me. No question. And more recently, in the last almost 5 years now, a different dynamic has occurred for the family. Having grandchildren now has been really quite a lot of fun, to say the least. And my grandkids all live close to us. This is little Ella and Andy. These are the two children of our daughter Lindsay, and that is her husband with the kids, as you see. And Sam is an attorney. Actually, he's a good guy. He's in that circle of trust, so to speak, because he's an M&A attorney. So we had no problem having him in the family. This is, again, our son Tony and his wife Rebecca, who is a pediatric dentist. And they have now an almost 8-month-old baby. Actually, she's not a baby anymore. I should show a picture of her grown a little bit, not bigger now, but she was born in February. So that's our third grandchild. And there's a fourth on the way, as Lindsay is now pregnant with child number 3. So been fun. Again, the dynamic is very special. Those of you that have grandchildren can relate to where I'm coming from. It's just been a joy to interact with them. Now, that said, from a professional standpoint, I've been able to wear 2 caps for 32 plus years of my 39 years of practice. I say that because I'm a clinician, yes, and still practicing 4 days a week, by the way, as well as an educator. And that cap has really been a fun one, because the journey has been just nothing but a pleasure and an honor to interface with so many wonderful individuals from all over the world, all 50 states and now 43 countries. We have just actually over 6,000 alumni. So that has been a terrific journey, to say the least. I've enjoyed it and continue to, because it really stimulates me to keep current as best I can with the different aspects of implant dentistry. We also have a separate facility for hands-on training, separate from the actual institute itself proper. It's a separate building that we're able to utilize, again, for a hands-on training. Now, important disclosure here, and that is that in this day and age of digital technology, we can grow bone, grow soft tissue, do a number of things at a push of a button. And I think it's super important to be very upfront and transparent about this, and that is that none of these images have been altered or manipulated. All of the images are from my own cases as well. I think this is super important, and I include this with all of my talks and courses and what have you. So, fully guided full arch immediate implant reconstruction, specifically the end-sequence prosthetic protocol. Again, I've been part of since 2009. This is a very interesting topic for lots of reasons, not the least of which is full arch immediate work is become very, very popular today. And I think there's no question that more and more individuals are getting involved, be it from a surgical perspective or restorative, or both. Some of our colleagues certainly are able to do both, and that's very interesting in of itself, and commands a skill set that really is divided into 2 different sections, but can be mastered certainly by one individual, and a lot to be said for that, for sure. So my topic will focus on a number of different items, as I'll show you the agenda here in just a minute. But the evolution, I think, is what's been important to stress here. And Terry mentioned something about that early on as we chatted before we went live. And it's just been interesting over these 13 years plus that I've been involved with this company. So here is the agenda. We will focus a little bit on the All-on-4 history, just to get everybody kind of on the same page, so to speak. I will touch on diagnosis and treatment planning only from the standpoint of, again, because of time constraints, certainly, I want to really focus on just briefly where and why we would use the guided protocol as opposed to, say, brain guided. We'll briefly look at armamentarium, the actual workflow for the end-sequence prosthetic workflow, and then finally case presentations, and wrap things up. So First things first, with regard to some history, where it all started, of course, we know that obviously the credit must be given to Dr. Brandemark with his team way back in the actual 60s and 70s, where immediate full arch, I should say full arch fixed work, not so much immediate, but full arch fixed work became something that was interesting in and of itself, the concept. And from then, of course, fast forward to the present, as we say, the rest is history. But this was back in the 60s. So to put everything in proper perspective, I mean, a number of individuals that I know I'm addressing right now weren't even born. That's a for sure. I was actually, to be quite honest. Dr. Schnittman and his group presented back in 97. This was kind of a landmark article, in that they were the first in the States to really talk about immediate loading. So that was interesting to kind of begin things, get the momentum going, more or less. But the all-on-4 concept in of itself is one that, as we know today, is not limited, of course, to just 4 implants, but for sake of discussion and to be more or less to properly address the phrase, if you will, all-on-4, it really literally means that 4 implants can more or less support 12 teeth in each arch, as long as they're, assuming they're spaced accordingly, et cetera, as we know. But the history again focuses on the fact that it is termed a graftless approach that maximizes quote unquote available bone. I'm going to talk on this a little bit more detail a little bit later here, because graftless to me is a bit of a misnomer, as we're going to see. The inventor, Palomalo, certainly gets credit for this particular innovation. I had the pleasure of spending a week with him and his team a number of years ago, and it was very interesting, to say the least, and an eye-opener, and one that really got me cranking, so to speak, with full arch immediate work. So again, Palomalo, Bo Rangert, who was an engineer with Nobel for a number of years, unfortunately passed away some years back. But these 2 individuals really get the credit for the all-on-4 concept. It is trademarked by Nobel, just for sake of discussion. And again, that graftless solution we'll talk about here a little bit. So first things first, regarding the validation of this particular concept, interesting, there are a number of articles now, actually hundreds, that have been published, different studies, et cetera, validating this concept. And one of the first articles from the Mello Group was in 2003, where they showed a 98+% success rate, 3-year time frame, specifically dealing with the edentulous mandible, followed then by an edentulous maxilla study. Again, high 90% success rate. And then the landmark, I would say, call it landmark article, at least for the States. It was in the ADA Journal back in 2011. Very nice longitudinal study done that indicated quite well validated once again that, you know, success rates of these cases very, very high 90 percentile for even up to 10-year follow-up, as you're seeing here. 94.8, called it 95% at 10 years. But the prosthesis survival rate, though, at 99% at 10 years. Very impressive, to say the least. So obviously conclusions are that this protocol works quite well, quite predictably. Systematic reviews really carry the most weight, as we know, in terms of validation. And these were the 4 that really jumped out to me, that made me really begin to think and understand better and appreciate that, yes, in fact, tilted implants do work. I'm a Misch disciple from many, many years back, back in the late 80s, early 90s, having taken all of Carl Misch's courses and being able to create a science base for the first time for all the work that I'd done in the 80s and moving forward. But the long and short of it is that, you know, moving from having implants lined up parallel to each other, and all of a sudden, what are we looking at? Tilting. How does that work? Well, again, these systematic reviews opened up my eyes and allowed me to become more open-minded, so to speak, and of course, adopt the entire concept. So in a nutshell, once again, the principles, strictly speaking, all on four implants, as we know in each arch, we know that. Posterior tilted, of course, axial, the anterior implants are axial placed. Whole concept is focused on immediate loading and primary stability in basilar bone. That's really the bottom line, where we're really seeking remote areas of bone that are of basilar nature, not alveolar. Very important. And hence, long implants can be utilized as a result, and tilted, of course, so that we're maximizing our AP spread and minimizing cantilever length. And therefore, we can immediately load these cases, as we know. Now, the traditional approach is, as you see here, can take a number of appointments from A to Z. Record taking typically is one appointment, as well as treatment planning. But from that point forward, the surgery then is done, and it's a conversion concept. As we know, a number of our colleagues continue to use this same concept, and it's labor intensive because the lab element is quite this analog version is quite labor intensive and really not a lot of fun. A number of us have gone on to the digital workflow world, especially primarily on the restorative end. Yes, for us, it's been almost 6 years using the PIC system. So photogrammetry has really revolutionized the cases that we do brain guided, and really minimize the actual time with our patient, which of course translates into convenience for the patient, for us, safety elements, you name it, a number of pluses in allowing that workflow to be streamlined so much better now in the digital world. But again, back to the conventional conversion protocols, the surgery is done, the denture is converted to a fixed appliance, and it can take a full day. I mean, anymore, I don't think this is too common most anywhere, due to a number of innovations, not the least of which is the smart denture conversion that is available to us. So in roughly 30 minutes, we are able to convert a case quickly with minimal openings within the prosthesis, as we know. So Brandon Coford gets credit for that, the brilliant prosthodontist from Cary, North Carolina. And of course, delivery of the final prosthesis 4 months later can take up to 10 appointments, depending on who's involved and what protocols are being used. But again, in the analog world. So what is exactly all on four? It's a concept. And I think this is the important point here, this discussion. It is a concept. It's more than just those key principles that we just covered. It requires a very big commitment to both the surgical and the prosthetic end of this particular workflow. In other words, what I'm saying is that the skill sets must be developed and mastered equally well, especially for those of us who are doing the surgery and the prosthetics. Even if you're just doing one, you need to have an appreciation, certainly for the other. But the attention to detail can't be emphasized enough. There's nothing, in my opinion, that really brings together virtually all of what we know in implant dentistry into one more or less base, and that is preying on our restorative background, our surgical background, hard and soft tissue work, etc. It requires a true commitment, a paradigm shift, if you will. And unless one commits, I really believe strongly that really should not be involved with this particular protocol in general. That is of immediate full arch fixed work, and definitely with guided as well. So a true commitment is important. And with regard to paradigm shift, what are we talking about? Well, if we strictly look at the definition in our dictionaries, it's a fundamental change in our approach or underlying assumptions. It's more of a jolt, if you will, of some, of a mindset that has to be altered. And in fact, what we really see is dependent on our perspective. And in other words, what our mind is trained to see. The word paradigm actually comes from the Greek root of paradigma, which really means pattern. And when I say pattern, the pattern we expect to see, is on the left-hand side of this slide. And for many, many years, I, like a number of our colleagues in the time frame, the 80s and 90s into early 2000s, for sure, sinus grafting, 6 to 8 implants for overdenture work, no less. It could be fixed, certainly, but these RP4 prostheses, very, very popular, but took a long time, of course. In other words, sinus grafting, 8 months roughly of healing time, plus the implants, another 4 months roughly, and then the prosthetic element, et cetera. So took a lot of time, cost a lot of money, but that's the pattern that we expected to see in the maxilla in particular. Whereas the pattern we now see is you see on the image, the right-hand side of the slide rather, and that is that obviously we have full arch immediate fixed work that can be done now, and really has revolutionized the entire industry, no question. Now, with all that said, those of you that know me at all know that I have been involved with grafting, bone grafting, for quite a few years. In fact, from the beginning of my practice back in 1983 through the 80s, I really worked with basic ridge augmentation procedures. But it wasn't until 89 when I did my first sinus graft, and now more than 1,500 lateral wall cases and hundreds of crystal cases later, I can tell you that I still do grafting, yes. Matter of fact, not as much sinus grafting for sure, lateral wall in particular, because of the type of approach that we use now for our full arch fixed work, yes. And I also performed quite a few block bone grafts over the years. Don't do as many now as I had in the past, again, for a number of reasons, not the least of which is there are different ways to skin a cat, so to speak, with conventional guided bone regeneration procedures, et cetera, et cetera. But I bring up these 2 slides for a reason, and that is that bone grafting still plays a role, not so much blocks, but some sinus and definitely basic grafting of extraction site defects and path defects, even with our full arch cases. And there's something to be said also for soft tissue work that needs to be done with a number of our cases. So the term graftless to me was a misnomer from when I even first saw it, because I really understood and believed and know full well the kinds of cases that I'm involved with, and in particular in the maxilla, that I don't like the word graftless as opposed to graftless. And a number of folks have talked about this particular term over time. But really, I just think it's more appropriate to look at this as grafting less, yes, in terms of volume and frequency, I should say. But when all is said and done, I think here's the bottom line. We have a number of different ways to skin a cat. There are different terms that describe virtually the same thing in terms of our conversion cases to take patients that are edentulous or partially edentulous, that so-called terminal dentition, teeth that are in trouble, and we can convert them into a nice full arch fixed or even full mouth of fixed teeth at one appointment. And there's just a joy to be had by not just the patients, certainly, but by we as clinicians, by us and our team for sure. But what I'm showing you here is just a number of terms that really describe virtually the same thing, a conversion kind of concept, an analog approach, if you will, to full arch immediate fixed work. So therefore, conversion denture, as we've been talking about, is in order. And that's what all these procedures have in common. So I like to term non-guided surgery as a reactive system. In essence, a almost not necessarily a knee-jerk type reaction, but definitely reactive in that we're reacting to prosthetic items, as you see here, a number of them that are listed, from AP spreads to bone volumes and density, you name it. And we're playing off of these factors, prosthetically speaking and surgically speaking as well. So in essence, we are able to visualize at time of surgery intraoperatively the different anatomic landmarks that we're familiar with, et cetera. But there's more of a reactive element going on here versus a proactive approach. And that would be what guided prosthetics is all about, in that this type of behavior allows us to act in advance of a future quote unquote situation. By that, we mean we're able to plan in the virtual world exactly what we want to do from a surgical and a prosthetic perspective. And this is something that's been very impressive and resulting again in a nice paradigm shift for how we can go about our full arch fixed cases. So again, this collage is showing you what conversion protocols are all about, and those of you that continue to use these protocols know exactly what I'm talking about, as well as those of you who no longer work with a conventional analog approach. We have certainly the digital world to be in now, and because of that, we are able to take advantage of this fully guided protocol, specifically from end sequence. Now, the literature really is very clear on accuracy of guided surgery, be it dynamic navigation, even robotic, and certainly with fixed guides. And this particular article is just one of many, many that talk about the fact that guided surgery should be considered to quote unquote improve accuracy for multiple implant cases in edentulous or partially edentulous sites. So a very nice study done, and as well as this particular article, again, emphasizing the importance of guided surgery for higher predictability and accuracy than freehand surgery, even in fact, especially in the hands of experienced surgeons. And I think there's something to be said for that. And I know a number of us get little, maybe big-headed at times and think, gosh, I mean, there's no question, I've been doing this so many years now, and 35,000 implants later, do I really need to have anything guided? Or it's well, the short answer is sure, why not? And why not have some accuracy in advance of your work? So let's just look now at diagnostic treatment planning concepts, very general. Again, I'm trying to squeeze into an hour and a half or two of time, what I normally would cover in 3 full days, and even much longer in our brain guided courses. So there's so much material. And in fact, just on diagnostic treatment planning, there's several hours of material that we look at. So this is just going to give you a 30,000 square foot, a 30,000 foot view of what we're wanting to share with you. And that is Ed Bedrosian, our good, great colleague, an oral surgeon from San Francisco, came up with a really nice system that I think all of us, a number of us, have adopted, and allows us to kind of have a common vocabulary. When we speak about a full arch case, specifically in the maxilla, we can talk about zones, and these bone zones are rather impressive, so that we can have a true descriptor of what we're talking about. So zone 1, as Ed shows, is basically the premaxilla. So if we have bone in zone 1, then we know in our mind's eye that we have bone from cuspid to cuspid. By bone, I mean adequate bone for root form implant placement. Zone 2 is the bicuspid area. Zone 3 being the molar region. So collectively, zones 1, 2, and 3, if we have good division A bone throughout, then we know we can place implants in an axial mode and not worry about tilting, of course, at all. And then we can also look at maybe zone 4, if we want to call that zone 4, then the zygoma bone. We can go further into the vomer, maybe call that zone 5, paranasal zone 6. So we can go on and on. But for sake of discussion, I think it's important that we at least address these 4 zones. So if we then take those zones and talk about groups, now it becomes a little bit more clear in terms of what kind of cases, what type of cases can we really guide and guide predictably. So group 1, for example, implies that we have bone in zones 1, 2, and 3. And I just mentioned that. So therefore, if that is true, then as you're seeing here, implants are lined up axially, no need to tilt. can place 5, in this case 6 in the maxilla. So very straightforward. Of course, if we ever see bone like this, which might be one time a year, we drool over the idea that, oh my, can do this blindfolded. Typically, these are patients that have no money. So much for that, that excitement. It's rather temporary. Typically, that's Murphy's Law for sure. We look at group 2. Now, this is implying that we have bone in zones 1 and 2. So therefore, the premaxilla and the bicuspid region. This is by far the most common group that all of us see with our patient base. So therefore, we will take advantage of the typical all-on-4 concept. So therefore, we will be tilting implants typically posteriorly to avoid our maxillary sinuses, of course, and then axial placement anteriorly. This is a typical all-on-4 type case. So bone in zones 1 and 2, group 2, by far the largest group that we deal with for conventional full arch fixed work in the maxilla. Takes us then to group 3, and this is what we term the hybrid zygoma group, because there's only bone in zone 1. So having bone only here in the premaxilla implies that we have nothing, or I should say inadequate bone in zones 2 and 3. So how can we have an adequate AP spread and accommodate our patients for 12 teeth on average? Well, the answer here, the solution, is a single zygoma implant in each side. So therefore, it's termed a hybrid zygoma arch, if you will. And we do these rather routinely. And this takes care of X% of our patients. Actually takes us right up into the 95th percentile of all the patients that we'll see. And finally, group 4, I term it the no zone bone, because there's literally no bone in any of the zones, i.e. zones 1, 2, and 3 have nothing. So therefore, what do we do? How do we handle these patients? We can sinus graft some of them, sure, come back and place implants, conventional. But in a number of these cases, there is such severe atrophy that even sinus grafting doesn't really fit the bill because of a tremendous anterior cantilever, et cetera. So typically these cases are in the quadzygoma realm and definitely demand the highest degree of surgical skill sets without question. And this is part of what I teach in my zygoma course, which coming up actually is next week. Our second one for this year had been sold out now for a number of months, and our next course will be, I believe, in March. So at any rate, this is a specialized area of implant dentistry for sure, where we're dealing with zygomatic implants. But if we look at groups 1 and groups 2 and lump them together, this represents approximately 80% of all the patients that we'll see in our practice in terms of the maxilla. In other words, what I'm saying here is that we're able to zero in on this patient particular base of, in other words, having great bone in all 3 zones, or at least in groups 1, in zones 1 and 2. And because of that, this is the 80 percentile of folks that we can guide. And by guide, I mean using the unsequenced protocol, we can very predictably guide these folks nicely in terms of the surgery, the prosthetics, et cetera. It lends itself beautifully to that. As opposed to now groups 3 and 4, if we lump them together, equals about 20% of our maxillary cases that we'll see, of which I will tell you, if we look at group 3 only, which means a hybrid zygoma patient, only 2 zygoma implants, then that's roughly 95% of everybody that will treat in the maxilla. The other 4 to 5% fall into that severely atrophic maxilla realm, i.e. edentulous, certainly, and that's about 5%. So that's the quadzygoma patient. Very big difference between group 3 and 4 in terms of skill set development, et cetera. And again, that quadzygoma commands the greatest of all skill sets in my humble opinion. So again, I teach all of this, yes, but the reality is in that particular course, I think what's important for everybody to know, just to keep things in perspective for what it's worth, is that the hyperzygoma patient is one that we can treat rather nicely, but rather predictably, and not have to get into the realm of that quadzygoma. Those patients really should be treated by surgical-based individuals that have a vast experience with orthognathic surgery / advanced level surgery, not necessarily be surgeons only, but folks that have tremendous surgical backgrounds, because this commands not just a skill set to do the cases, but to deal with the morbidity that's associated with them. So in a nutshell, what I'm saying here, just to go back to the previous slide, is this is the subset of patients that we look at for full arch guided kinds of cases. Now, not to say that our hybrid zygoma and even quadzygoma cases can't be guided. No, we do guide those actually. However, not in the sense of being able to have prosthetics involved, et cetera, as is true with the in-sequence protocol. So let's move on to our third section here, the agenda, and that is armamentarium. We'll just briefly go through this because it's important that if in fact we're going to guide implants and have a guided prosthetic element involved, but for sure the surgery, there has to be a designated guided surgical kit. Should go without saying. And today's, I'm certain that most all implant companies throughout the world have a designated guided surgical kit. And the reason for that, of course, is the drills have to be elongated for this particular protocol, meaning it's a stacked system. So therefore, using physical guides, the drills have to be longer than conventional drills for sure. So that said, you can see that these drills are manufactured, in fact, specifically different lengths so that they can be utilized with this particular workflow. There are drivers that are designated for the implants themselves that allow for placement into the implant body so that it, again, can transcend through the guides and into the into bone. So these drivers then have, and again, every system, every company has a little bit different way of going about more or less monitoring the depth of the implant placement itself. So here you're seeing one way of doing things where there's different stops, and these markers, depth stops, actually have disposable stops or even non-disposable. Aggressive thread design, very important for all of these cases, no question. And I do believe today most all implant companies have some type of aggressive thread design that really allows us to get primary stability right off the bat, and that's very important. Multi-abutments, this is a very important element. These abutments allow for correction of angulation issues. When we place tilted implants in particular, we can correct up to 1730 degree with some systems, even more so with other systems. And important that these abutments be utilized in a proper mode. And there's, of course, protocols for all of what I'm sharing with you. Again, just to give you a quick overview, these angle torque wrenches come in handy nicely. Back action rongeurs, as I'll share with you here in just a bit, et cetera, et cetera. So again, just down and dirty, so much material to cover. I'm giving you just, again, a quick overview. But now, regarding the specific workflow for this fully guided approach, it's very impressive, to say the least, and it's evolved again over time. But the bottom line here is that the prosthesis is designed and actually fabricated in advance of the surgery, and that the entire surgery is guided and digitally planned. So as we're going to see here, there are digital records that are required, 5 of them in particular. And if we're looking at them one by one, clinical photos should go without saying. I think in this day and age, we'd be very remiss to not be validating all of our cases and taking pictures of all of our patients, certainly. So clinical photos are in order to start. A bite registration, teeth together with indexed, of course. We can do this analog, we can do digital. And full arch impressions. Now, a number of years, we've been able to utilize a digital workflow, certainly. But that bite registration in the mouth and then the patient being scanned is very, very important, because this is at the heart of the entire workup. Because if this step isn't done properly, then everything will be accurately inaccurate from this point forward. And that's not a good thing, of course. I will tell you that I have a great appreciation for the lab element of what does happen at N-Sequence in Reno. It's a very, very well thought out methodology that has been developed over time, a very accurate one, to say the least. And last but not least, the digital dental lab slip is filled out. So those are the 5 digital elements that are important to be sent, by the way, at one time to the lab. So now the workflow is continues, as you see here now, that the digital 3D data set is then merged with a 3D bone structure from our cone beam CT from the DICOM file. So we have STL files, we have DICOM files. So we have a complete 3D patient-specific data set that's formulated. And that serves as a foundation for accurate 3D planning without question. At this point, these fused patient 3D data sets are now ready for planning, and that's when we go online with the lab in Reno, and we have a particular lab technician that we get involved with, myself as a surgeon, or any of our surgeons for that matter in our group, along with Phil, our prosthodontist. We're able to now have a true interdisciplinary team web meeting in every sense of the word, a true collaborative element going on here. And that, again, it's a software-driven interdisciplinary virtual workup that is happening. And all of these facially driven treatment principles are incorporated and ultimately virtually implemented. That's the key here. And when all is said and done, we're able to, at that meeting, by the way, which really can be very brief and typically is, early on, it may take 45 minutes or so, and you might think, wow, this is crazy. Why would I spend all my time, in front of a screen? I've got enough issues to deal with my computers during the day, et cetera. Well, bottom line here is, like anything else, repetition really will allow us to be more efficient, so that when all is said and done, these meetings really are very brief, because we know each other's wants and desires, so to speak. The lab element knows that we want either 5 or 6 implants that we've indicated, for example, in the maxilla. They'll position them to start, and then we can, on our end, control with the mouse where those implants need to be, all commanded and dictated by the prosthetic setup of the teeth, of course. So this is kind of a virtual wax up, so to speak, that you'll see. And then ultimately, the manufacturing element allows the monolithic PMMA material to be formulated in such a way that the prosthesis is then milled and available for us day of surgery. So this, again, the teeth are milled from this monolithic puck and bonded teeth. And finally, last but not least, there's laboratory validation. How does this occur? Well, my gosh, it's a fantastic item here, an element in that there's actually dry model surgery going on, and in 2-jaw cases, cross arch matching and what have you. It's just a very sophisticated, labor-intensive way of doing things. But when all is said and done, the accuracy is ridiculous. It is so spot on that if there is a problem, typically it's on our end, on the surgical end, intraoperative end, if you will. So finally, of course, day of surgery, the prostheses are able to be picked up and then incorporated into the workflow as you're seeing here. So day of surgery, again, the teeth have been made in advance. The surgery is guided completely, and then the teeth are able to be placed accordingly. So for us, it's been, again, about a 13-year ride, and I've enjoyed it with my team, and having taken part in a number of the innovative elements that have gone on over time, it's been a lot of fun. So with that said, let's turn now to some case presentations for the duration of our time together. This is Joanne, and Joanne presented as a young lady in her early 50s at the time, school board education person, unhappy with her teeth, her smile, her gaps in her teeth, and she felt that they were increasing. The gaps were with time, etc. So the long and short of it is this is how she presented to us to start. We had several sessions with her to make sure that we ultimately could achieve what we felt would be good for her in terms of final fixed work. Not everybody is a candidate for immediate full arch fixed work, as you can imagine. We're very careful to make sure that our diagnostic element is there, and the treatment options are always given. Always, there's never one option only. That's never a good thing, as we know. One diagnosis, many treatment options. So very important to appreciate that. Morton Amsterdam certainly was the first to talk about that years ago in the perio realm. So here we see what Joanne looks like, both facially and intraorally. You can see a typical collapsed occlusion, lack of posterior teeth, splayed maxillary teeth, etc., some periodontal involvement, on and on. So a lot of things happening here. Our photo analysis really gives us a lot of information that we can translate to our lab. And again, we see a lot of problems here with Joanne. So again, selective extractions could be in order here, with implant placement ultimately to still give her fixed work. Sure, she would need periodontal work, some endodontic work, etc. So lots of things happening potentially to save some teeth, yes. And again, we gave this as an option to her, and she didn't really think too much about that. She had a neighbor who had immediate full arch fixed work done, so she kind of was already in her mind made up. Her mind was made up, I should say, in advance of what she wanted to do. But very important that we spend time with our patients to truly make sure that they are grasping the depth of what we're attempting to share with them, because these are life-changing procedures. Self-image changes virtually all the time, yes, for the better, but we want to make sure that we have a stable patient from a psychological perspective. A lot to be said for that one, but also from a true, anatomic perspective, what options do we have to give them? So we're off and running. Here, impressions were made, models were made, and then translated digitally, as you see here. Obviously, cone beam CT is at the heart of what we do, and certainly reduces surgical risk and complications across the board. That should go without saying. In 2005, when I embraced this technology, it was looked upon as somebody kind of being way out there somewhere. Why would we subject our patients to all this radiation, and why this and why that? Well, from that point forward, all of my patients, literally every single one of my patients, get scanned, whether it's a single tooth case, obviously, or even up to full arch immediate work, etc. Everybody gets a scan. So the workflow, again, is, as I mentioned, virtual implementation of what we are able to do. These more or less digital wax-ups are impressive, because when we have that go-to meeting, we're able to literally see the original setup of teeth, in other words, existing dentition, and then a virtual correction, if you will, accordingly. So it's very impressive. We can evaluate virtually the condyles into the respective glenoid fossae, etc. A lot of information can be had, but most impressively is the entire workup is, as you're seeing here, the pre-planning. The ostectomies are pre-designed and pre-planned, as you're seeing in this case, a two-arch situation. So we can appreciate the amount of bone reduction that's necessary for adequate restorative space. And the planning is just so impressive. I can't begin to tell you how impeccably detailed these cases are, so that we're able to interact once again with the lab folks. And we have, again, our surgical individual, our restorative, and lab all at one time on these meetings, these virtual meetings, and we're able to then dictate and show exactly based on the restorative element. In this case, the for sure the occlusal view. We're able to appreciate then, when we place the implants in these cross sections, that are invaluable to appreciate the respective anatomy. There's so much detail here that's very impressive. and most importantly, very predictable, very accurate for sure. So all this is done virtually. We're able to know number of implants we want in terms of length, angulation, and diameter. All of these parameters are implemented at this point in time virtually, and then of course translated into the lab elements. So what's done in the maxilla, of course, can be done in the mandible, as you're seeing here. So in this case with Joyce, as you're seeing, we're off and running, and this is what's provided by the folks at InSequence. In other words, there's detailed information that is sent to us as part of the package, so to speak. And what you're seeing here is the virtual treatment planning at a glance, frontal, occlusal, left and right views for this particular patient, for example. And then a planning overview is presented and shown to us so that we can see at a glance the type of implant we're placing, length, diameter, angulation. Multi-abutments are selected in advance, as you're going to see, et cetera. There's so much that, again, is involved here. But the planning scheme is just most impressive because at a glance, and by the way, these different sheets are pretty much placed all over the operatory on the walls before surgery, so that at a glance any of us could look at and say, okay, let's see better where that particular implant is going to be and what have you. Any questions, et cetera, are answered immediately. But the planning scheme is impressive. Different densities of bone can be shown and appreciated at a glance. And once again, the same sequence of events occurs in the mandible. That was all the maxilla, of course. So the planning scheme, once again, number of implants, specifically where they're placed, so we know they're coming. I should say they're designated in 3 dimensions in the correct position. So in this case, with the mandible, 4 implants were going to be placed in these particular sites. And this is what you will receive in a box for each arch. So 1 box per arch. If it's a dual arch, of course, you'll have 2 boxes, but you have compartments with all these different parts and pieces and models and what have you. So the beauty here is that you'll receive what you're seeing on the left-hand side, which is nothing more than a flight plan, if you will. In this case, 19 steps are involved. And it's important that, step 1, 2, 3, 4 in order are followed. If you go 1 to 5 to 7, you're going to crash, of course. So as you're seeing on the right side, all these different guides and parts, pieces, you name it, are laid out. And it's overwhelming at first. I will tell you this, that I did this for the first several cases, at least 3, 4, maybe 5, as my staff looked at me thinking, oh boy, here we go. He's coming up with something different again, and just give him some time and he'll probably forget about it, is what they were hoping. But the reality is it takes really a good 8 to 10 arches to really feel comfortable yourself as an operator, as a clinician, but also for your team to feel comfortable. And before you know it, it becomes like an orchestra. Everything is kind of just orchestrated so well that everybody knows what everyone else is doing. My staff knows exactly the sequence of events. Again, there's the protocol that's given to you in advance. And as you do more and more of these cases, then again, the workflow becomes just something natural and you don't even think about it. So this is a great book if you haven't read it. A classic, been out a number of years now, but the Checklist Manifesto by Gawande really, I think, puts things in perspective quite nicely, because that's what it's all about, is nothing more than a very organized checklist, so that each case is planned so well in advance. So this is all laid out, time of surgery, and it's a very proactive approach, I think, as you would imagine. So now, that said, let's look specifically at the surgery for Joanne. As is true for all of our cases, we use an IV sedation technique. In fact, the majority of our cases are deep sedation, where we use a propofol pump. But at any rate, most important is these folks are very relaxed, comfortable, and of course, we'll, in a 2-arch case, we'll address the maxilla to begin. And this biplane confirms accurate mounting of the case, as you're seeing, so that in essence, what we're seeing, attempting to show, is that validation of everything that transpired in the lab was good because the bite that we originally submitted to the lab is now coming back to us in the form of this acrylic bite plane, if you will. So now you may ask, well, what if this is off? Well, it hasn't been in all these years yet. I'm sure it's going to happen at some point, but the reality is if it's off, however much, it can be accommodated for intraoperatively. So local anesthesia, of course, is administered, and our typical approach, whether we're doing brain-guided surgery or truly guided surgery, the incision designs are basically the same. Again, for sake of time, I'm not going to get into too much of really surgical protocol, other than to tell you that certainly flap reflection is in line. Crestal sulcular incisions, I will say, take your time taking teeth out. This is important. Not a lot of folks spend time on this, and grip and rip many times is what it's about, but not really. Very important, because if we don't take our time here, as you're going to see, the bone foundation guide, which is seated around the alveolar process, could be really not, you can have quite a problem seating it if you've expanded, for example, the ridges for any reason at all. So extraction of teeth, of course, and soft tissue trimming. Anatomic landmarks are important to identify. In this case, in the maxilla, our nasal mucosa is, as you're seeing here, piriform rims, midline vomer bone, and lateral nasal walls, etc. And then throughout the arch, different other landmarks are identified. And of course, it's important that we have the ability to cauterize any bleeders, be they bone or soft tissue. And this is, of course, should go without saying. Been using now the Sonoquence radiosurgery for the last several years. But first things first now, regarding the guided elements, see, this is what's important. This bone foundation guide is at the heart of what this is all about. And that is, once that flap is reflected, you're seeing this is an older version of what is available today, meaning these are three separate struts that are part of this entire acrylic framework that is now metal as of the last few years. But at any rate, again, this iteration is such that there were separate struts and they were screwed in, very crude by today's standards, certainly. But bottom line is, this foundation guide was seated in such a way and then accurately placed such that the struts allowed the opposing arch, in this case, the teeth of the mandible, to engage into these indentations to correctly orient the guide. So once all that was done, then the foundation guide could be pinned into position, the struts removed, and fast forwarding to a different iteration, a more recent one. This is termed a monostrut because all of these individual struts that I just showed you were unified into one particular unit. And there is actually the teeth here served as the orientation to the opposing arch as opposed to indentations. So in terms of dry model verification, once that foundation guide is in place, then that's the amount of bone reduction that has to occur. And if we use, for example, a reciprocating saw and just made a continuous cut across here very accurately, that would equal this particular piece of acrylic. So in essence, what we're saying is these two, this equals this. In essence, that's how accurate the workup is. And it's very easy to quickly do. I like to take a back action rongeur and save this bone for grafting purposes, and then finish off with a round fissure burr, as you see here. So virtual to lab to clinical. This is proof of concept of how this entire process works. It's a stack system. The surgical guide is then indexed into the foundation guide, and the surgical guide then allows us to place these implants through the guide, and I should say allows us to create the osteotomies first, and then the appropriate implants into the through these master cylinders. So it's all thought out quite nicely. And primary stability, of course, is what it's all about. Our drilling protocols dictate that. We'll prepare osteotomies, as we know. We make sure that our implant type is has an aggressive thread design, We use longer implants, again, for greater bone implant contact. And more recently, in the last 6 years for me, osteodensification has entered into the picture in terms of primary stability, and that's a whole discussion in and of itself. So again, once these implants are placed, then the mounts are oriented accordingly. And by the way, these little blue lines, as you're seeing on the guide, allow orientation of the mount in such a way, depending on the implant system, so that we know depth is accurate, depth of the implants themselves. And once that has occurred, the surgical guide is disarticulated, and of course, appropriate bone contouring is done, multi-abutments are placed, and then we can try in the actual prosthesis over these handles, shortened handles that we make and allow to be placed into the multi-abutments. And finally, we're able to then use this gasket that allows for clearance, if you will, of the copings that are placed then onto the multi-abutments. And again, all of this is pre-designed and made in advance. In other words, any copings that would have to be cut anymore, we don't cut them, but when they were cut, they were done in advance, so there's no lost time of surgery. And that gasket, of course, allows for pickup of the prosthesis without any leakage through and around these copings. So at this point, you're seeing the prosthesis seated and indexed, and now we're able to pick it up in terms of using different composite flow items. We're lubricating our prosthesis in such a way that we don't want to have any interference within these circles, so that we can have pickup with the composite, the flowable luting agent. And as you're seeing now, we're able to pick the prosthesis up very predictably. And now, once that is done, we're able to unscrew and remove that prosthesis. We are blocking out, of course, the copings. And what was used, but not anymore, was a so-called clear bridge. And in its place is nothing more than a second prosthesis, pink. And why not? Because it makes all the sense. But the thought process here was an interesting one, because this is the light cured, as you're seeing. And just as was done with the pickup of the prosthesis itself, this is a clear bridge, as it was termed. And because of that, that can then be used later for the final restorative work. But now, by today's standards, I show you this for historical purposes because this really isn't necessary anymore. But it did save some time, because you can remove the long-term provisional from the patient, place the clear duplicate bridge. And of course, at this point in time, what is important is that the soft tissue drape be addressed. In other words, there's been shrinkage of tissue over the 4+ months of time from the provisional placement to now fabrication of the final. So aesthetics are developed or evaluated rather, and bite, etc. And then, of course, the final impression, in this case using a light body or medium body PVS impression, etc., removing that clear duplicate bridge and seating the long-term provisional back into the patient's mouth. And all of this is sent to the laboratory. So the second restorative appointment, really, if needed at all, there can be some fine tuning done. But in essence, if a third appointment is necessary at all, that's when the final prosthesis is seated. So a very nice workflow. And as you can see, these long-term provisionals are really well done, and maintenance issues really have been zero. I can tell you, early on, we had problems in the early years, different materials, yes, but by today's standards, this is really not a problem. So as you can see, this duplicate long-term provisional bridge eliminates a number of restorative appointments, no doubt. So back to this particular patient, again, to Joanne, our bone contouring is done. We're then able to place graft material within the defects. And this is important as I see it. I think there's something to be said for addressing extraction site defects, different other bony defects that are created due to periopath problem, or I'm sorry, endoperio issues, etc. So why is this important? Well, if you're following your patients long-term, you'll understand better what I'm saying. And that is that there's a restorative element that will occur with our cases. So from a both hard and soft tissue perspective, yes, you can see I'm grafting. There's exposed threads here. This requires, in my opinion, a true guided bone regeneration protocol, if you will, with not just PRF. That's going to be gone in 7 to 10 days. As we know, these membranes, they leach growth factors, VEGF in particular, to upregulate our angiogenesis, absolutely important. But we need a true membrane, a true collagen membrane cross-link with fixation to protect that defect. In other words, I should say to regenerate bone to protect the implant body long-term. That's very, very important. So again, graftless versus grafting less. I think this is the key. A number of our cases require bone and soft tissue grafting. And again, not a lot of folks talk about that, but long-term follow-ups of our patients, I can tell you that it's very important that we address both items. So then, of course, primary closure. And at this point, the prosthesis is handed off, and it's not a conversion. At this point, we term it a refinement of the guided maxillary long-term provisional. It takes about 25 minutes or so. And while that's happening, we're dropping down to the mandibular arch and dealing with that, etc. So now when we're in the mandible, we can begin our work. We've localized. We can then edentulate the arch after we've full flap reflected. And by the way, this protocol really mandates a little bit more reflection than you would for a non-guided kind of case, to allow for that bone foundation guide to be seated well. But again, the extractions are done. The upper prosthesis could be taken out if we wanted to make room for work in the mandible, but would have to be replaced because of indexing once again with that bone foundation guide in place, as you're seeing here. So once all that is done, then the foundation guide can be removed, and the what you're seeing, I should say, the bone foundation guide is not removed. The monostrut, in this case, the single struts are removed. The foundation guide stays in place to the bitter end. And there's the bone reduction again that has to occur very nicely, very accurately. And then the surgical guide is placed onto the foundation guide once again, as we saw in the maxilla. And very nicely, we can see what we're talking about in terms of being able to very nicely, very accurately create our osteotomies, place the implants through the guide, through these, through the prefabricated surgical guide, certainly. And we're able to then complete the entire arch this way, as we did in the maxilla. And at this point, the maxillary prosthesis is refixated. If in fact it was removed, we now bone contour the mandible, mandibular arch. We're placing our copings and our separator here. I'm blanking out on the name here. Goodness, the gasket, pardon me. So now the gasket is in place, and these copings, they used to be numbered and marked, what have you. They don't have to be anymore for a number of reasons. Again, different iterations of this protocol. But imagine now, not grafting these sites makes no sense at all. Very important to graft with true membranes again, and fixation, etc. And this unattached tissue should be addressed as well. So at this point, refinement of the lower arch is done. And as you're seeing, there's the intaglio view is nice and contoured well. Light curing of the prosthesis is done. And once again, virtual to lab to clinical. This is all just flows nicely. And these two arch cases, without photography, without video, can be done very, very quickly. We're talking 3.5 hours, 4 hours maximum. And that's taking your time and even encountering some glitches along the way, etc. There's really nothing to be so concerned about in terms of problems. So at any rate, I'll just quickly go through this video of Joanne to again, kind of summarize what we just showed you with slides. Taking these teeth out, very important. Take your time. I use a 6 and an 8 round burr to more or less, unless the teeth can come out very easily if they're periodontically involved. Otherwise, some are ankylosed. I just decornate and then remove the residual roots with these round burrs. This is important. So let me back up here. Seating this foundation guide, which by the way, today now is metal. It's not plastic, so it's more rigid. And it's important that it be seated accurately because, as I mentioned before, if there's a problem now with that foundation guide not being seated correctly, then truly everything from that point forward is accurately inaccurate. Very, very important. Here I'm just showing you some retraction sutures that we'll place to just act as almost an extra assistant to get the flaps out of the way while we seat that foundation guide, for example. So, and imagine if you were a little sloppy with your extractions and increased the alveolar ridge width, then the foundation guide would have a problem in terms of it being seated, or you would have a problem seating it. So important that a number of items be addressed, but here we are with the foundation guide in place, the monostruts removed, and now you can see how quickly, easily it is to do this bone reduction. And let me back up here just a bit. At this point, the surgical guide is placed, and I'm going to go through this protocol in a little bit different version so that you can appreciate it better here a little bit later. But with Joanne, this is a typical sequence that we would follow, dating back now, in her case, she's almost 9 years out. So this is still one of the earlier versions, but again, showed exactly what, needed to get done in terms of our keys for these drills, of course, the implants being placed through the guide, and the master cylinders allow for placement of the implants very nicely. And once all is said and done, we're able to, again, disarticulate that surgical guide once the mounts have been removed. And bone milling, our multi-abutments, they're pre-selected. See, this is what's so nice. Everything is done in advance. There's no guesswork. And by the way, where that multi-abutment is oriented is already done for you, because that's what, again, that little blue line lines up with the set screw itself. So a lot to be said for what is done in advance. That's why these cases are so well done in terms of efficiency for us. In other words, we save a lot of time because there's really not a lot of thinking that goes on. It's all done for you in advance because of the planning that was already accomplished via the virtual workup based on the record taking that's so critical with our patients, certainly up front. So again, multi-abutments in place, the small handles, and one by one, we place these handles and then verify the prosthesis for draw. Rarely do we have to open up any of the holes to make them a little bit bigger. Here you're just seeing a combination of the graft complex into the various defect. So ultimately the copings again are placed and the gasket, and we're able to verify the bite and pick this up nicely. Now, before the metal foundation guide was created, these were all, the foundation guide itself actually was indexed into the opposing arch. So we had to auto-rotate the mandible, for example, into position. Whereas today, we, using the metal guides, the foundation guides, we're able to use tooth-supported, I say they are tooth-supported so that the reference point is teeth, which means then we can very nicely pick this prosthesis up open mouth, don't have to auto-rotate the mandible, for example. So again, you're just seeing the pickup being done very nicely, clear dupe. And then a grafting, once again, how important is this to graft? I can't begin to emphasize the importance, especially in our very hypoplastic maxillas are thinned out. You can see many times translucency of the implant body through the facial plate. That's a real problem long-term if we don't address it with veneer grafting, meaning allograft xeno with a collagen membrane fixation as well. We know from Deftari and Bahat in 2013, I believe, the craniofacial growth continues in all of us till we die. It's not just ending at the growth spurt. So how important is that to be able to buffer the facial plate? I think there's going to be a problem for a number of our cases if we don't address that. Definitely down the road, no doubt. So again, a true membrane with fixation is important. In other words, a guided bone regeneration, if you will, kind of approach, a veneer grafting, as I term it. I've done this for many, many years with our conventional GBR protocols, but for full arch in particular, this is important. So again, we've addressed the maxilla. There's the mandible. And again, for sake of time, I'm not going to spend, rather bore you with the entire video, but the long and short of it is we're able to pick up the opposing arch now, prosthesis. And once that's done, we now will be grafting. So while my restorative colleague is handling the refinement of the prosthesis, I'm grafting and then, of course, closing. And now the prosthesis comes back. And it's being seated, as you're seeing here, and picked up nicely so that we're able to, now you're seeing foam being placed into the holes. My gosh, we used, of course, plumber's tape today, and just different materials in general have evolved over time. And there we are, the upper and the lower. So the time savings is just significant, without a doubt. So there's what things look like at a month out. Certainly there's going to be some shrinkage. We can put triad and our other materials to pick that up. So we began with, as you're seeing the presentation there's what things look like, again, a month out. So there's Joanne now progressing at almost 7 months in the provisional. The final restoration conventional would require a number of appointments, as we talked about, and all of that is just not done anymore. And when we do a brain guided surgery, for sure, with our photogrammetry basis for the digital workflow, then that's just a whole other element in and of itself. But again, here's Joanne 8 years out. And as we can see here, we had her in a zirconia upper, full arch zirconia, and composite build wrap, rather, on the, I'm not sorry, acrylic wrap on in the mandible. So that's an 8-year follow-up on her. And again, before and after. Now, just looking at a little different case, similar though, Virgie in her mid-70s at the time, presented to us with issues in the maxilla. You can see a canted arch for starters, but not so much just an aesthetic issue, but from an overall mechanical issue, restorations failing. Lower arch very stable, and we're able to redo that nicely, but conventional crown and bridge work. Class 2 deep bite, typical collapse bite, again, what we've seen very often with a number of these types of cases. So we're off and running, and again, the virtual treatment planning allows us to very predictably show where implants should be placed in an optimal position three-dimensionally. And again, in terms of length, in terms of height, diameter, angulation, you name it, all of these parameters are dealt with right now in the sagittal plane. So we're able to orient the implants accordingly, align them well, and then we're off and running with our surgery. As you're seeing here, once again, the extractions are done, the foundation guide is placed, and again, it's very important that you appreciate the value of that foundation guide, because it's a stacked system here. So that foundation guide serves as the true foundation for everything that follows, meaning the monostruts, in this case, single struts, based on the time frame that they were made, of course, chronologically. But most importantly is that that foundation guide does so much. It allows us to see how much bone we have to reduce quickly. The surgical guide then gets seated into that. Different iterations of that surgical guide today of how that's fabricated and made overall. But then we have our guided surgical kit, of course, to allow us to create our osteotomies through these master cylinders with appropriate keys, et cetera, et cetera. Good primary stability. And here you're seeing 5 implants, proof of concept. There's our lab element from the virtual workup. And then here's the clinical manifestation of it. Exactly the same. And again, our multi-unit abutment placement, et cetera, et cetera. Copings are seated. And our dual cure flowable composite pickup allows us to then have the refinement of the prosthesis while again ungrafting these residual defects, extraction site defects, et cetera. Keep in mind, PRF once again is used for one purpose, and that's to upregulate VEGF, increasing angiogenesis to the site. True collagen membranes are used once again for any of the defects that require true grafting with autogenous bone ideally, and any particulate allograft that we have to add to that, along with xenos for veneer grafting. And again, the refinement, approximately 25 minutes or so, and there's our completed bridge. So here we are again with Virgie, able to see and appreciate the surgery at a quick glance, extractions as we talked about. Again, the foundation guide in place. Once it's indexed, we remove the monostrut, in this case, single struts. And there we are with the plasty of the bone. And once again, the value of the surgical guide, and these little blue lines allow us to orient very nicely the thread timing, and hence the vertical placement of the depth, if you will, of the implants, et cetera. So all of that is done quite well. And the multi-unit abutments, again, they're keyed. They're all keyed, pre-selected in terms of angulation, whether they're straight 17, 0, 17, 30, or greater, depending on the system that you're working with. All of that is pre-selected, makes things so much nicer for intraoperative timing, et cetera. So there's the prosthesis again. I'm sorry, the multi-abutments completed placement, and now the copings. And there's the gasket that allows for blocking out of any residual flow of the composite material, dual flow. Here, these indexes are not needed anymore. We do them tooth supported, so therefore the prosthesis can be placed without auto-rotating the mandible. And here we are. So let's just go right into, there's a 3.5-week follow-up, as you're seeing. Provisional scan taken, at 4 months, and a 7-year follow-up with Virgie. Again, very predictable, very accurate, and most important, intraoperative time is just reduced dramatically. So there's our cross sections that really you want to see this type of effect always in terms of your implant placement, allowing good bone volume on that facial plate, because that's going to wear over time. And very important that we appreciate that issue and prevent problems that can occur later. And our last case that I'll share with you is that of Ed. It's just an amazing fella who came to us with actually he had dentures that he did not wear. And it was just, he wore them for looks, he said. And when he went to eat, he would take them out of his mouth. Very, very sad situation. So in a nutshell, we were able to work with a new set of dentures, of course, here as you're seeing, with fiduciary markers. And here we had the luxury of a fair amount of good keratinized gingiva in the maxilla in particular. Mandible, not as much, but enough to potentially do this case flapless. I'm not a big fan of flapless, to be honest. But in Ed's case, I realized he had good bone volume from the workup here with the scan, division A bone in both arches. So I thought, let's go for it. Let's go for a true all-on-4, meaning 4 implants each arch and flapless. Why not? So here's our diagnostic dentures, as you're seeing here, digitized, and the optimal setup, as you're seeing as well. So now with the workup, again, the virtual workup, we're able to place these implants strategically in locations that give us the best AP spread. Of course, we know that the importance of that to minimize cantilevers. So we're back here to the second bi and up front in the lateral central regions. And again, our cross sections show in both arches what we have planned. And now in this type of a case where we are going flapless, and again, I'm not a big fan of it for a lot of reasons, not the least of which is accuracy. Soft tissue based guide is definitely not as accurate as a bone or even tooth supported guide. That's a definite. So there's a bit of an issue in terms of real true accuracy. At any rate, I had to say I did one, and this is the one I did. Here it is, how many years ago. But what I'm getting at here is that we have tissue supported guides, both arches. There's the bite, the right side. And therefore, once the patient is in occlusion well, then we can fixate both guides, both upper maxilla and the mandibular guide, remove, of course, the index, and then remove the lower. In this case, to start, we would remove the lower guide and repin that later. But now addressing the maxilla, of course, we have our tissue punches to remove the tissue itself, the plugs, and then allow us to create our osteotomies, and then proceed, as we've shown you before, implants placed again through the master cylinders appropriately with mounts, etc. And we'll do this in both arches. And once all is said and done, as you'll see here, we're able to do this rather quickly, efficiently. We can core out more tissue, reduce tissue thickness as we need to. And then ultimately, each of these provisionals is placed, as you'll see here. Occlusal contacts at time of insertion, minimal amount of adjustment. And that's a 2-month follow-up. Now, this kind of a procedure done, obviously, flapless, both arches, edentulous, upper, lower. Think about it. I mean, if you with no photography, no video, then we're talking, my goodness, a matter of just an hour and a half max, and you're done. If that, in both arches, completely done. So again, there's going to be gaps in time with tissue shrinkage. Those are picked up. And as you'll see here, it starts to start trimming his mustache and looking better overall, feeling better about himself. And as we know, the self-image changes that occur in our patients are dramatic at times. I mean, just absolutely over the top. And as you'll see here, and you'll hear from Ed here in the video just a bit, happy he was. But here's a 4-month follow-up. And once again, 8 years later, almost 9 now, zirconia in the upper arch and acrylic wrap downstairs. We've been using little different materials here in these last years, nanoceramics we played with, and different copy mill approaches. But again, here's an 8-year follow-up, zirconia upper, acrylic wrap lower. And let's hear from Ed. I don't know if we can have the volume up here on him or not. May not have connected that. So, well, at any rate, what he's saying in a nutshell is kind of comical, because he's very happy with his teeth for sure. But I think the most important part here is that he talked about eating pizza just days after his surgery. And I thought, oh gosh, you got to be kidding me. I didn't know this until I'd seen the video. It was kind of funny, but most importantly, what he's really sharing with us is that he's so super happy and that it changed his whole life. And there's no question that we see this all the time in our patients, no doubt. So I want to wrap up this entire protocol with this little video that will, I think, put things in perspective in terms of the entire workflow that I just shared with you. So it's about 7-8 minutes here of time that we'll use to just address this important element. See, here's the foundation guide being seated. And again, this is call it a 4.0 iteration. There's since been the metal version that we allow work with the existing teeth. So we don't take all the teeth out at once. We sequence them literally. So instead of auto rotating that mandible like you're seeing here, we would just use one arch by itself, in this case, the maxilla. But here, imagine, just appreciate this is a monostrut, one unit. And once we've indexed this and fixated our guide, we can then remove these pins and disarticulate this foundation guide. I beg your pardon, the monostrut, pardon me. So the foundation guide is intact, as we've been talking about. And the amount of bone there is what will be removed to allow for adequate restorative space. There's that back action rongeur we talked about. And we'll harvest this bone and keep it for grafting any defects that exist. And then that large round fissure burr allows us to complete the alveolectomy, alveoloplasty. And here we're just making sure that we've removed adequate amount of bone volume. There's our surgical guide. It happens to be indexed into the foundation guide. And then pins are placed into the surgical guide to fixate that prosthesis. I should say that guide, the surgical guide itself, into the foundation guide. And now the appropriate keys, depending on whatever system you're playing with, they all have keys of some type that allow, they're specific to each drill diameter. And of course, in our course, we have a designated hands-on section that goes through all of this in detail so that one's able to see lecture discussion material, of course, videos of surgery, live surgery, and then, of course, hands-on. That is pretty much the entire spectrum of how we like to teach here at the Institute. So here you're seeing the implants, of course, being now placed through, again, those master cylinders. These mounts have to be placed and threaded into the implant body to allow for placement and being able to torque these, because again, it's a stacked system. So you need elongation of this entire complex. So once the implants are threaded into position, we know exactly where to stop. And also orientation of that implant, especially if it's going to utilize ultimately a 17, no, any off-angled multi-abutment, then indexing becomes very important. Obviously, an MUA of 0 degree would not require any angulation, or I should say any orientation issues. So now the mounts are removed. Surgical guide will now be removed after the pins have been, faster pins have been displaced here. And now what we're going to see is, of course, the underlying implants in place, going to require some bone work, some bone milling, and that would be done at this point. Always the tilted implants will require bone work, creating what I call a ramp distal, like you're seeing here, with an 8-round burr, and then circumferentially to make sure that the multi-abutment can be seated completely. It's very important. So just giving us ourselves some running room, so to speak. And now the respective multi-abutments are placed. Again, orientation has already been planned. So that little set screw is opposite the lines on the foundation guide. So we know exactly the correct orientation of each multi-abutment. So there's the carrier and the screw hole, and then there's the index line. All these line up. When you eyeball that in a straight line, you know you're spot on. One of the many advantages and beauties of this particular system. So now the copings are placed one at a time. These are non-engaging copings, of course. This was at a time where they were actually cut in advance. Now we don't need to have them cut at all, for that matter. But either way, there's the flat side should be on the facial. There's two flat sides, doesn't matter which one, but one should be to the facial to orient them accordingly. So at this point, we're placing the gasket, and it's secured around the base of each coping. This is important to make sure it's seated well, and then block out. These are nothing more than just straws that are we're able to block out the each of the copings, and then of course the prosthesis will be able to be placed over and around each of the copings. Excuse me. And we inject our luting material, light cured, removing the blockout straws. And of course, the coping screws to allow for the prosthesis to be removed and refined. And of course, while that's happening, the surgical work is then done. The final work is done, meaning bone grafting and, of course, soft tissue closure. So here the gasket is removed. And it's at this point that the foundation guide is removed. It's done its work. Great name, foundation guide. Truly, it's at the foundation of everything that we've shared with you. From that point forward, it's all predicated on that guide. In other words, the accuracy of the final prosthesis, fit, everything. So at the end of the day, you know, we can talk about protocols, we can talk about technology, and there's so much to be really discussed. Honestly, days and days of material to really look at. But at the end of the day, it's really about our patients and what they experience. And it's important that we don't lose sight of this. Sometimes it's easy to get caught up in, I'm as guilty as anybody, you know, in the neatness of whatever procedures we're doing, get mesmerized and all that. But bottom line here is we can't lose track of the fact that our patients' self-image changes so dramatically. Some folks more than others, certainly, but to just see that beautiful look on their face when they see their teeth, and even not just at time of placement, but even months later and years later, as they're coming in for recall visits and maintenance and what have you, they just continue to exude the excitement and the confidence that they didn't have before. I mean, how many of our patients have shared that with us over time? So we're truly transforming lives. There's no doubt about it. No question in my mind. And it's very satisfying for us as clinicians and our team, certainly as much as I think for our patients. And folks like Kenny, who came to us from Haiti and always smiling and really happy-go-lucky no matter what. But when all was said and done with him, look at the before and after, and you know that just smile is even bigger and better. Again, feeling so much better about himself. And then, you know, James, who only mid-40s at the time of surgery, you know, just rarely smiled. We had to really provoke him to give us a big smile pre-surgically. And then, of course, after the fact, ecstatic, and gave us an amazing testimonial, video testimonial, one of the best I think we've ever had. And Deborah, who's a school teacher for special needs kids, unfortunately had a bad accident with one of the teenagers, butt-headed her and just caused some significant psychological trauma for her. She actually went into retirement from that. And we were able to help her out. And when all was said and done, my goodness, talk about a transformation of a life and a self-image. She's one of our best ambassadors for our practice. She just tells everybody about how happy she is and how well she was treated, et cetera, et cetera. And then Lucy, who came to us from the Netherlands, an abusive situation with her marriage, and she fled the country with her daughter and came to the States. And she was a real challenge due to symmetry and some other issues, but we were able to address her problems ultimately and give her a very, very good result that once again, you could just see in her eyes and her face how happy she is because of, again, her teeth and how important our teeth to all of us. Are you kidding? The smile is the most amazing item that we all have. And when we look at our, fellow man and woman, what do we eyeball to? We look at the mouth, we zero in right in on the face, on the smile, certainly. So for our patients, we're changing lives, we're transforming their lives, absolutely. But just in summary, to compare a conventional denture conversion 2D freehand with our computer-guided 3D pre-planned, no doubt that the planning is way more sophisticated. I would think you would agree. The virtual workup, no comparison to many times 2D planning on the other side. In terms of interdisciplinary treatment planning, it doesn't get any better here. A true collaborative accountability is in order. Absolutely, as George Mandelaris talked about many years ago. I can tell you that this is as good as it gets in that respect as well. More patient appointments with our conversion protocols, I would say yes. We can streamline so nicely with our computer-guided 3D pre-planned for workflows. Less chair time, how important is that from an anesthesia perspective, from a safety perspective, from a morbidity perspective? You win each time. Materials, no question here. These are different types of provisionals compared to conventional denture conversion. We know the acrylic gets its strength in bulk, so therefore coring out big holes and what have you through a denture, not a good idea. Very predictable, patient-specific, and affordable. I would say that once you start comparing costs and what have you, really be surprised that way better to go with a computer-guided approach. And from a medical legal perspective, I don't think it gets any better, honestly, if you think about what I've just shared with you in terms of the materials that we get directly from nSequence, the boxes of the models, the actual sheets of documentation of the case from A to Z, the entire sequence of steps, on and on and on. We have so much documentation, it's crazy. So from a medical legal perspective, no comparison with typical denture conversion protocols. So at the end of the day, we're looking at reactive once again versus proactive. And I think this is so important because at the end of the day, also what this also means to us is less stress. And I think that's the big take home thing here now. And that is that we all want to be less stressed. I think we would agree that in this day and age of everybody's in a hurry, everybody wants to get things done yesterday, et cetera, we have now a workflow that really gives us the ability to chill at the time of surgery. Those of us that are surgical based, not a lot of thinking has to go on, quite honestly, because so much of it has been done in advance. And hence that's really at the heart of what this fully guided nSequence prosthetic protocol is all about.